Just to get everybody on the same page, systemic lupus erythematosus is a multisystem autoimmune disease that affects virtually every body system. I'm not going to spend a lot of time here. In particular, as I'm a nephrologist, we look at lupus nephritis, and if you see this as the normal glomerulus, if you remember from medical school or your physiology studies, the filtering units of the kidney, you can see that in various types of lupus, this is very much destroyed, and if this continues unabated without treatment, you wind up with a dead kidney requiring renal transplantation or dialysis. So this is very similar to what Rob showed this morning, but we know there's lots of omic variations and eventually down to the phenotype with proteomics and metabolomics. Since this has been discussed, we'll kind of skip the details here, but I want to go through each one of these major categories very briefly and try and show you how this is or is not being applied to kidney disease, and this of course has implications broadly as well. So looking at the transcriptosome, I'm going to try and pick out things that I think are major discoveries over the course of the last few years. Looking at peripheral blood mononuclear cells from kids with lupus showed an interferon alpha signature. And you can see this here. These are lupus patients, and these genes are all interferon dependent, and they're all upregulated. Controls were rheumatoid arthritis and then healthy people. And you can see almost 100% of the kids showed this signature. Interestingly, in adults, only about 50% of the adults show the interferon alpha signature. And I'll show you another picture of that in just a minute. And we don't know if the adults have a distinct subset with the interferon alpha pathway usage, or they were simply inactive at the time of sampling. Also from this work, you can see that these patients, this is 3 examples of 3 different patients who were treated, this is before treatment, and then with high-dose corticosteroids, and you can see that this turned off in at least 2 of the 3 patients the interferon alpha signal. I've also picked out a couple of genes that I think will find some relevance later in the talk when we talk about proteomics, just to kind of keep this integrated to show that these methods are complementary to each other. Now, type 1 interferon there had been clues that type 1 interferon was important in lupus, but it's very difficult to measure interferon alpha in serum. We did know that when you gave interferon alpha therapeutically, it was associated with the appearance of autoantibodies and in some patients clinical lupus. We find tubular reticular inclusions in kidney endothelial cells in patients with lupus nephritis, and that's illustrated here. And these are a interferon footprint. They're very common in states of excess interferon alpha production. Lupus serum inhibits viral-induced cell death, and then it induces monocyte to dendritic cell transformation, and that's blocked by anti-interferon alpha. So this is actually done, this is a similar heat map looking at the interferon signature in glomeruli, and these were laser-captured glomeruli and then examined for gene expression, and these are from adults. And there was a series of about 12 patients, and you can see here some of these patients had a very prominent interferon alpha signal, and some did not. And interestingly, what we find in the kidney is plasmacytoid dendritic cells in class 4 and 5 lupus nephritis, and these cells make a lot of interferon alpha. So there is a link between what we're seeing on the signal, the transcriptosome, and what we actually know exists in the kidney. Interestingly, there's another series of patients who have a lot of B-cell transcripts, not surprisingly in a disease associated with autoantibodies. And in fact, when you look at the interstitium of patients like this, you see that there are a lot of T and B cell aggregates, sometimes even forming germinal centers in the kidney. So the cells that mediate these processes are found in the kidney of patients with lupus nephritis. Uh-oh. Okay. So there seems to be a central role for interferon alpha in the immune pathogenesis of lupus. And so the real question is, has this transcriptomic analysis helped us? And I think the answer is yes, because there's several implications for therapy now, and these are new drugs that are being trialed. And first of all, in the plasmacytoid dendritic cells, which make interferon alpha, the antimalarials, hydroxychloroquine, for example, and new anti-toll-like receptor antibodies are being trialed to turn off the response of plasmacytoid dendritic cells to the uptake of immune complexes. Additionally now, in trial for lupus, not lupus nephritis yet, but lupus, are interferon alpha antibodies and antibodies that interfere with the interferon alpha receptor. So interferon alpha plus IL-6 tends to force the plasmablast into plasma cells, which could be autoreactive and produce autoantibodies. And there's currently a trial in lupus nephritis using a biologic that is an anti-IL-6. And finally, interferon alpha in association with B-cell growth factors and B-cell survival factors promotes B-cell transformation to plasmablasts. And currently belimumab and atacicept, well, atacicept was actually taken out of trial because of toxicity, but belimumab was one of the only drugs actually approved by the FDA in the last 50 years for the treatment of extrarenal lupus, and this will be trialed in renal lupus very shortly. So as you can see, this kind of analysis has informed drug development and drug trials in patients with lupus and lupus nephritis. In the interest of time, I'll skip this. We'll go to genomics, and I'm just going to spend a very short amount of time here. It turns out, not dissimilar to what you've heard this morning, that in this very complex and heterogeneous disease, we don't have genes that are associated with high odds ratios, except for some of the complement pathway genes, but these are very rare. What I really wanted to point out was that candidate genes have really informed the genomics here. So for immune complex processing genes like complement or FC receptor genes, all of these that were found on GWAS were actually candidate genes that we had looked at, not we personally, but we in the group of the lupus community had looked at in the past. Similarly, here's the toll-like receptor type 1 interferon pathway. And again, most of these were candidate genes that were confirmed later on by GWAS. Now, in some of the immune signal transduction genes, these are discovered new genes that are being looked at now in lupus and lupus nephritis that were discovered by GWAS. The point is, if you look at the odds ratios, this is very similar to what some of the earlier speakers had indicated. These are very small odds ratios. And what this means is that the genetic risk for lupus is probably derived from variations in a large number of genes with very modest size effects. We've talked about this. The other thing I want to point out is, like Rob from was talking about with metabolomics, much of this work has been done mainly in Caucasian populations, and of course lupus is a disease of ethnic groups, especially lupus nephritis is more severe in African Americans and Asians, and so we need to extend the genomics studies to these groups. Now, proteomics is something we do in our laboratory, and I'll feature some of our work. One of the important things, as the nephrologists in the audience know, is that the interstitial injury to the kidney is very important in determining the prognosis, even though these diseases are considered glomerular diseases. So if you have a normal-looking kidney here with a normal-looking interstitium, and you develop in lupus and lupus nephritis severe interstitial inflammation, which is very common, you have release of a bunch of inflammatory mediators. This leads to interstitial hypoxia, and eventually what you develop is interstitial fibrosis and tubular atrophy if you don't intervene at this step. Now, it turns out that if you look at the best correlates for renal failure, so this is maintenance of renal function, this is renal failure, as you increase your interstitial nephritis, your chances of maintaining kidney function to support you without dialysis or transplantation are severely diminished. So, What we generally do in the nephrology field is we analyze these types of findings with kidney biopsies, which are invasive and uncomfortable for the patients. And so what we wanted to ask was, could we find, in lieu of the kidney biopsies, urine biomarkers of interstitial disease that could be used to follow therapy and help us in management decisions for these patients? So in other words, we treat these patients with immunosuppressive drugs. We try, which are very toxic, as most of you know. We've borrowed most of these from the field of oncology. And these are difficult to use, and if we don't really have this kind of real-time analysis, and we don't really do a lot of repeat biopsies, a lot of the use of these medications is through clinical variables only that are not very sensitive. So we did urine proteomics to discover biomarkers of kidney pathology and lupus nephritis. We obtained urine at the time of diagnostic biopsy. We started to look for the cut of proteins below 30 kilodaltons because we were looking for things that may mediate disease, and this is generally in the small molecular weight protein range, growth factors, cytokines, et cetera. Compared to all of the techniques you've just heard about this morning, we used a rather primitive technique of cell-Detoff mass spectrometry, primarily because that was available to us at the time, albeit with Dr. Freitas now we're collaborating and we've become significantly more sophisticated. We graded the urine specimens. Actually, our pathology collaborators graded them in a blinded fashion, and this is very typical of what we do in nephrology. It's semi-quantitative, and you can make the argument that we need to be more quantitative with this, and that's something we're working on. But this has worked well for several decades in nephrology, none, mild, moderate, and severe, and you'll see those terms in a minute. And so we identified 169 proteins in the 2 to 20 kilodalton range with a very good signal-to-noise ratio, and these were peptides present in more than 50% of the samples. We considered them for statistical analysis. I'm not going to show the whole group, but what I show here is that some of these peptides we did identify. This was the mass-to-charge ratio, and they were associated with interstitial inflammation. And I've highlighted one in particular here, which was completely unexpected, but that's one of the fun things of doing discovery proteomics, and it's hepcidin. So what is hepcidin? And this is work from Xiaolin Zhang in my lab and others. Hepcidin is an iron regulatory protein. As you can see, with increasing degree of interstitial inflammation, hepcidin went up in the urine. And when we actually looked for hepcidin in kidney biopsies, we found that it was present in patients with lupus. Here's a nice low power view, not in the glomeruli, but in the interstitial infiltrating leukocytes. And then Xiaolin went on to show that if we isolated human monocytes, IL-6 and interferon alpha, again trying to integrate with what we learned before from the transcriptosome, actually increase the mRNA of hepcidin several-fold. And both of these, of course, IL-6 is on the pathway of inflammation in the kidney, and interferon alpha may be one of the master controllers. So we felt this was very interesting. We weren't exactly sure what an iron regulatory protein was doing pathogenically in the kidney, but certainly as a biomarker, this was provocative. So we asked the question, could urine hepcidin predict the level of interstitial inflammation without a biopsy? And of course, the answer is absolutely not as a single biomarker. This misclassified 40% of the biopsies. It had a moderate sensitivity, low specificity, and a very poor positive predictive value. And you can see why here. Here's patients divided into no interstitial inflammation or mild versus moderate or severe, and you see the significant degree of overlap. Now, keeping on with this theme, we looked at other individual urine proteins, and they suffered basically the same fate as urine hepcidin as a biomarker of interstitial inflammation. Now, in terms of the omics field, neither one of these, urine MCP1 or urine LFAB, were discovered via a proteomic approach. Rather, this was a candidate approach that we had done previously in our laboratory. MCP1 was pretty good in separating, but still had a 16% misclassification. And just to remind you, MCP1 is part of the interferon alpha signature. LFAB is liver fatty acid binding protein, and of course, like many things, it's made not only in the liver, but in the proximal tubules of the kidney, and is thought to be an injury marker. And so we, as a best guess, thought this might be relevant as well in interstitial disease. And you can see here there's considerable overlap. So we asked a different question, and this is also something that was kind of talked about by Wolfgang, is how about the interactions between these things? He was talking about gene-gene-gene interactions, and we thought maybe we should look at more than one biomarker to see if we could increase the accuracy of our testing. And so we used linear discriminant analysis to combine clinical and urine biomarkers, and our clinical biomarkers are pretty simple right now for kidney disease. We're not nearly as advanced as the oncology or cardiology fields. We basically have proteinuria and serum creatinine. And so we did every combination of serum creatinine, urine protein, and the 3 novel biomarkers, or potential biomarkers, in 64 biopsied lupus nephritis patient urines. The goal was to differentiate none to mild inflammation and fibrosis from moderate to severe inflammation and fibrosis. The reason for that was, as if you recall on the slide I showed you earlier, these patients did generally very well. These patients tended to progress towards chronic kidney disease or renal failure. And we derived equations that actually combined various biomarkers. And in this case, the equation for interstitial inflammation combined urine MCP1 and serum creatinine. And this was the cutoff level that was derived by our statistician. But as you can see here, this gave us a very good receiver operating characteristic curve with the area under the curve of 0.92. Misclassifications were only 14%. Sensitivity and specificity were quite good. Positive predictive value was pretty good, certainly better than individual biomarkers. Negative predictive value, 100%. We're pretty confident in this equation, and so now we're going to start to try and verify this in a different population as part of a validation cohort. We did the same thing looking at tubular atrophy and interstitial fibrosis. We didn't do quite as well. Misclassifications were about 22% with less sensitivity and specificity, and the area under the ROC curve was only 0.72. The point is that using this same type of analysis, we can add more biomarkers and change this equation. So as we find biomarkers either via proteomics or through other candidate approaches, we can add them to this equation, modify it, and see if we can improve this. And I'll just say one thing, that in kidney biopsies, there may be a 10% misdiagnosis rate or no diagnosis rate. So we're not too far off from a kidney biopsy. You can visualize this being part of something in a laboratory diagnostic test, and then we can use this to serially follow patients as we treat them. And knowing that inflammation is the precursor to fibrosis, if during our treatment inflammation is not changing in a patient, we could sustain our therapy. On the other hand, if inflammation is working well, we can reduce our therapy and reduce the exposure of our patients to cytotoxic agents. So I think this really does have very practical implications once it can be validated in an independent cohort. Now, in terms of a little bit more sophistication, in collaboration with Mike Freitas and also with our pathologists and Dr. Sadaskar is here, we're doing laser capture microscopy of these patients. And what we're doing is we're taking out the glomeruli or interstitial areas and then exposing those isolated portions of the kidney to a proteomic analysis, LC-MS, and this is really has been dependent on some of the technology that Mike has developed in his lab to allow us to do this from the residual tissue that's remaining after a clinical kidney biopsy, which is very remarkable. So you know that a lot of people have done laser capture and have done actually looking at mRNA, but very few people are able to do this successfully. And although although this work is in its preliminary stages, I'll just give you a little bit here of what we've discovered. These are spectral counts which roughly correlate with protein expression. And as you can see here, if you look at glomeruli, things that are upregulated are certainly the complement components. We know that this is an immune complex disease, and this makes sense. Complement should be upregulated in patients with class 4 and class 5 lupus nephritis. Some of the matrix proteins are upregulated. I put this in because this is MX1, which you saw on the transcriptosome early on, which is an interferon alpha dependent protein, and that is also upregulated, particularly in class 4 in the glomeruli. Interestingly, in this technique, we can also see things that are downregulated. Synaptopodin and podicin are both very important components of the glomerular basement membrane and the foot processes, the little diaphragms that help us be selective in our filtration. And you can see here that as we go through the various types of kidney disease, these are markedly downregulated in the kidney, and this has actually been shown not only for lupus, but also for other types of glomerular injury in kidney disease. Similarly, in the tubular interstitium, we do find things that are upregulated, and again, I will point out that this is an interferon-induced transcript and protein, and that's markedly upregulated, particularly in class 4. And then some enzymes are downregulated in the tubular interstitium. And of course, this is a very incomplete list. I just did this for illustration purposes. Let me just, I highlighted tenacin here because one of the things that we need to do is say, okay, these are changed in the tissue. Is there a way to measure these if you're going to use these as biomarkers more easily? And of course, we like to look in the urine. And as you can see here, this is using an off-the-shelf ELISA for tenacin, and these are bland kidney biopsies. This is proliferative lupus nephritis, and this is lupus nephritis that's proliferative plus membranous. And you can see here that the tenacin actually, the protein is actually found in high quantity in the urine of patients, just like we saw in the tissue. So indeed, this is proof of concept that at least some of these things that we're finding in the LCM tissue do come out in the urine and may be potential for a diagnostic marker that can help us follow therapy or diagnose the disease. Finally, metabolomics, and this is very brief. I'll be done very shortly. The concept you've already heard about. There's variations in approaches, global versus focused profiling. And then the strength of this, biomarkers from metabolite profiling can be translated from the preclinical stage, animal investigations, to the clinical setting, as many of the endogenous metabolites are species independent, whereas the transcripts and proteins often show species variations. There has been very little work done on this in the kidney in general, certainly in the urine in general, and in lupus specifically. There's one study, it's somewhat old at this point. NMR was done in extracts of the MRL-LPR mice or control mice. MRL-LPR is a mouse model of lupus nephritis. Several metabolites were found. You've heard about the branched chain amino acids this morning. Those were increased, so maybe that isn't specific to chronic kidney disease, as was mentioned this morning. This was, and also glucose was increased, and this was due to, then they went on to look at this. There was increased glucose transport into the kidneys, and it turned out that when these investigators blocked complement activation, which is very relevant to the pathogenesis of renal injury in immune complex disease, they decreased glucose transport in lupus nephritis. So again, this was a metabolomic approach that brought together two very disparate areas that one would not have anticipated simply from our current state of knowledge of the literature. They hypothesize that complement activation leads to increased renal glucose content. This might increase TGF-beta and SMAD3, which have an influence on extracellular matrix and thus enhance glomerulosclerosis in lupus nephritis. So again, this is a very preliminary study, but it provides proof of concept that the metabolomic approach may yield relevant information, not only in lupus nephritis, but as we heard this morning, also in chronic kidney disease. So, just to wrap up, I know everybody's anxious for lunch. To answer this question, have the new omics, and now some of these are less new than all the little categories of omics that you heard about this morning, have they really given us new insights? And I think the answer is definitely yes for the transcriptosome, and certainly the transcriptosome has informed the genomics, and so this will start to pick up steam. I think proteomics is yielding now a lot of good information that could be used in terms of how to follow patients at least, and then how to use current therapies. And then, of course, we want to extend this to new therapies. Metabolomics is just starting, but certainly has some potential. And I'll conclude there. Thank you very much.
I think we have time for just one quick question. Yes?
Lupus patients who do not yet have kidney disease,
Yes.
are they anemic?
Are they anemic?
Yeah.
Well, some are. If you're saying, is that a potential biomarker to predict, actually anemia has been looked at and maybe does, but not very well. One of the interesting things, and I actually skipped this, was in pediatric lupus, one can predict the development of nephritis later on by finding large granular neutrophils in the PBMC fraction. I kind of went over that quickly. So we and others are looking for predictors of who's going to develop lupus nephritis. The answer to the anemia is not all of the patients are. Some are, and some of that's because there's antibodies to red cells that causes hemolytic anemia. But I thought the large granular neutrophils were particularly interesting because we find those in our laboratory as well in the adult population, and so they may be predictive of people who might develop disease in the future.